Hi everyone, my name is Tu Nguyen and I'm a medical student at UCLA David Geffen School of Medicine. I'll be presenting a case of hypervirulent Klebsiella pneumoniae liver abscess infection in a newly diagnosed diabetic patient. So liver abscesses are the most common type of visceral abscess, and historically E. coli has been the predominant causative bacteria. However, within the past decade, a hypervirulent or hypermucoid strain of Klebsiella pneumoniae, or KP, has emerged. It was initially reported in Asia and is becoming more prevalent in other parts of the world, most commonly afflicting patients with diabetes. So to bring us to our case, we have a 35-year-old male with no past medical history who presented with 4 weeks of recurrent fever, chills, night sweats, emesis, and a 20-pound weight loss. On review of system, we learned he had also been having polydipsia, polyuria, and sensation of incomplete voiding. On presentation, he was afebrile but tachycardic to 140. His physical exam was largely unremarkable, except for notable diaphoresis. In terms of labs, he had a leukocytosis of 15.8, elevated glucose of 412, an elevated ALT, AST, and D-dimer, and his A1C was 11.4%. Urinalysis showed glucose of greater than 1,000, 3 white counts, bacteria was present, but leukocyte esterase and nitrites were negative. Urine culture was positive for gram-negative rods. As for imaging, chest X-ray and TTE were unremarkable. Here are some notable findings on the CT of the abdomen and pelvis. In this first figure, you'll see a liver abscess measuring 3.2 centimeters. Although not seen on this particular cut, there was also a small thrombus extending into a branch of the right hepatic vein, which explains the elevated D-dimer. In the second figure here, there's heterogeneous enhancement of the left kidney, and the third image shows small abscesses in the prostate. Now moving on to the most exciting part of taking care of this patient, we took a field trip down to the lab to look at his blood cultures. And in this first image that I captured here, you can see hypermucoid colonies of KP. Now here's a close-up of the second image. We took the end of a Q-tip and stretched out one of the colonies. If it stretches out greater than 5 millimeters, as seen here in this picture, this is considered a positive strain test, which is a phenotypic indication of the hypervirulent strain of KP. Now let's go and review his hospital course. The patient was initially given broad-spectrum antibiotics, and his hyperglycemia was controlled with insulin. Urology and IR did not perform drainage of abscesses due to its small size, and there was no easily accessible fluid collection seen on the right upper quadrant ultrasound. The patient was ultimately placed on ceftriaxone, which is one of the most potent antibiotics for KP. Unfortunately, he improved and was transitioned to PO ciprofloxacin just before discharge. At follow-up, he was doing well, and a repeat CT showed decreased size of liver abscess from 3.2 centimeters to 15 millimeters, and there was also complete resolution of prostate abscesses. Additionally, his A1C improved significantly. It decreased from 11.4% to 5.6%. To wrap things up, this case demonstrates one of the presentations of the hypervirulent strain of KP. It most commonly causes liver abscess and can often disseminate to other organs like the brain, spine, lungs, and eyes, and as seen in our patient, the prostate and kidneys. The main risk factor for acquiring this infection is diabetes, and as seen in our patient, this infection can have an insidious and nonspecific presentation. And one last point I want to make is although the strain of KP originated in Asia, it has now been reported in other parts of the world, such as Africa and Latin America. Given the prevalence of travel, this infection has also been increasingly reported in the US, which underscores the importance of considering this virulent infection in the immigrant population, especially those with diabetes. That is the end of my presentation. Thank you for listening.